Hello, my name is Hassan Magdi. I'm a specialist of diagnostic and interventional radiology. I'm going to talk about the core role of interventional radiology. Let's imagine that inside this room is a piece of cake. Okay? I want a piece of cake. Who doesn't want a piece of cake? So there are two ways to get inside the room. Either through the door. If there is no door, I will have to break the wall. But interventional radiology offers two more ways. I can either drill a small incision, like 5 mm or so, and grab a piece of it, or I can enter through the pipeline. This is interventional radiology. Either percutaneous approach, I go directly towards the lesion I target, or I enter through femoral or radial arteries through a vascular route and reach my lesion. This is the end of my talk.
Thank you.
Interventional radiology utilizes minimally invasive techniques. It helps in both diagnosis and treatment of lesions. Benefits of interventional radiology include reduced hospitalization and recovery time, reduced surgery risk and anesthesia use, reduced infection, and reducing treatment costs. There are general precautions we need to take care of while performing interventional procedures, especially in the lung. Due to chest wall anatomy, we have a neurovascular bundle that runs along the inferior border of each rib. So the preferred injection site is the superior margin of each rib. We have to palpate with our fingers intercostal space and try to target the upper border of each rib. Okay? Lateral positioning also is preferred than posterior position approach due to within old age vessels become more redundant and the possibility of injuring these vessels arises. So lateral approach is preferred. Factors increasing pneumothorax risk include crossing multiple fissures or crossing emphysematous bodies, so we need to avoid these structures. Always repeated punctures pose more risk for pneumothorax. Forceful coughing during the procedure increases the risk of pneumothorax, so anti-coughing medication may be prescribed before performing the procedure. We must review imaging with experienced radiologists. As you can see here, we can report this as large central mass lesion and try to take biopsy. It's quite underneath the skin, so it's easy. However, on this MRI scan, we see small central mass lesion with surrounding lung atelectasis. So if we take the needle subcutaneously or just behind the chest wall, it will not yield a diagnostic sample. It will yield lung tissue. Role of interventional radiology, either diagnostic or therapeutic. Percutaneous lung biopsy is crucial for establishing diagnosis, especially in indeterminate lung nodules or patients with history of extrapulmonary malignancy. Also, percutaneous biopsy is crucial for increasing the chance of treatment. As targeted therapies expand, biopsies are increasingly used to obtain tissue for molecular testing. This case, it has an active pulmonary nodule, so we begin with marking the skins to ensure best route for intervention. So then we use local anesthesia to reduce pain for the patient. After this, the needle is inserted. We notice that the needle is inserted in the lateral portion of the tumor, so we are afraid that it will be non-representative sampling. So we insert another needle in the center of the tumor. Most common complications are pneumothorax and bleeding. There are multiple prognostic factors that control the rate of complications. There is a video I'm trying to play. lesions abutting the pleura have minimal risk, while those less than 2 centimeters have 7-fold increase in pneumothorax, while those more than 2 centimeters have less risk of pneumothorax. No risk associated with cavitary lesions. Smaller lesions tend to have higher risk than lesions more than 4 centimeters due to shorter procedure time. Lesions abutting the pleura have minimal risk of bleeding in comparison to lesions away from the pleura. Also, pleural effusion acts as independent protective factor against bleeding. We can mitigate the risk of bleeding in pneumothorax through performing different techniques. There is one called Pearl protocol, aims to decrease complication rate. This includes positioning biopsy side down, needle removal during expiration, using of autologous blood batch sealing, where we use patients' own blood to close the tract after performing biopsy, rapid rollover, and pleural patch. This protocol and this study published in 2021 found a profound decrease in complication risk against the control group. Therapeutic role of interventional radiology in lung malignancy, we can use percutaneous or endovascular in different scenarios. Percutaneous lung tumor ablation are alternative to surgery or stereotactic body therapy for the treatment of certain malignancies. Thermal ablation, we use either hyperthermal or hypothermal methods. Hyperthermal, where we use radiofrequency or microwave ablation. Hypothermal, which is called cryoablation method. Cryoablation utilizes a special type of probe introduced into the lesion. With repeated cycles of freezing and thawing, we reach tissue necrosis. Indications. For primary lung tumors, surgical resection is a standard of care for stage 1 to 3A of non-small cell lung cancer. Best candidates for ablation are patients with stage 1 non-small cell lung cancer who present the contraindications to surgery or radiotherapy due to cardiorespiratory comorbidity or insufficient vital lung reserve. Better outcomes are achieved when lung tumors do not exceed 2 centimeters. So, percutaneous ablation with curative intent should be reserved for T1A and T1B non-small cell lung cancer less than 2 centimeters. Percutaneous ablation is also used for pulmonary oligometastatic disease, mainly for metastases from colorectal origin. Treatment of more than 3 metastases and nodules larger than 2 centimeters are linked to worse overall survival outcome. Contraindications of percutaneous ablation include diagnosis of small cell lung cancer, higher stages of non-small cell lung cancer, presence of metastasis, untreatable coagulopathies, low survival, and end-stage lung disease, and when lesions are near important structures like hilum, large vessels, main bronchi, trachea, or esophagus. Endovascular techniques include embolization and stenting. Transarterial embolization, as Professor Talal talked to us, is used to manage chest tumor with causing massive hemolysis with more than 600 milli per day or more than 200 milli of blood per hour. This case shows a cavitating lung lesion, large cavitary squamous cell carcinoma, angiography reveals the supplying blood vessel, which arises from lateral thoracic artery. Feeding branches were implied with coils, and there were no tumor blush. Also, there's a syndrome called superior vena cava syndrome, where tumors are large enough to close superior vena cava with compression extrinsically. Endovascular stenting is used to restore flow towards the right side of the heart. This is a case of non-small cell lung cancer with SGC obstruction. We note that contrast is interrupted here. So after stenting is done, we restore flow to the right side of the heart. Here is the stent, and there is contrast going into the heart. Take-home messages. Interventional radiology offers minimally invasive techniques, and it helps in both diagnosis and the treatment of different lung pathologies. We must seek multidisciplinary approach as it offers patients best chance of treatment. Radiologists should be aware of important findings to report that can change the modality of treatment, like exact tumor location, size, number, and blood supply, putting in mind the various treatment modalities that the patients can benefit from. This is my mentors and colleague in gastrointestinal surgery centers. Can I have a round of applause for that? Thank you.